It's really a pleasure to be with you today. I want to thank you all for making it through the snow. I know we did have some folks come in from Denver, some of our colleagues from HICPOF, and drive safely going home. Really, it's amazing that it's been a year, because I do remember 10 or 12 days into the job standing before you, not really having complete understanding of what I'd signed up for. I kind of knew. I knew that healthcare was in a state of crisis. I knew that behavioral health was really an acute issue here in the mountains, and I knew that we needed to enhance access to more affordable care. I knew that Vail Health had a PR dilemma. I knew that we needed to be better community partners. But until you're actually out and about and talking with people and getting to know things more completely, you don't really have a full appreciation for the magnitude of the opportunities. But what I also didn't have a full appreciation for, which has been the thing that has made my first year here so great, is I didn't understand just how well this valley can come together, and how that when they're all working with one another, we can solve problems and do things like the Eagle Valley Behavioral Health Initiative, which you've heard a lot about, and do things about which you're going to hear related to enhancing access to more affordable care. Now, having said all of that, we've got a long way to go. We've only just begun. We haven't moved the needle far enough. And so what I'm going to talk to you about today is not just what we've done to date, but also what we're going to do going forward. And then most importantly, Michael or somebody, I need you to keep me on a clock and give me, 5 minutes before, such that there's 30 minutes left for questions and answers. We're not going to break out into different groups today. We're going to keep it one big group. I only ask that when you do have questions, please be mindful that there might be a lot of other people who have questions, and try and make them relatively brief, and then I will stick around afterwards to talk with you one-on-one if you like. Make sense? Okay, let's get going. So we try to always use our mission to ground us, to guide us. And in healthcare, it's pretty intuitive that your mission should be about providing good healthcare. And you can read ours here. I'm not going to repeat it. But it's a really important thing when we're talking about the state of healthcare being in such a crisis. And it's also important because part of what's wrong with American healthcare, besides it costs too much and you can't understand it, is that it's really been sick care. It's not been healthcare. What do we have to do within our communities to ensure that the mind, the body, the soul are all being tended to? And how do you actually start to blend in social determinants of health? And what does that mean when you move from sick care to health care? And this is something that requires community-wide involvement. And it'll ultimately continue to be our compass as we talk about addressing some of the problems about which you're going to hear. So when we talk about community health, there's a variety of different ways that we can go out and gauge this. There is a community health needs assessment that came about through federal law. It's really related to the Affordable Care Act and ultimately the IRS requirements for nonprofits. Our colleagues from the state, from the Healthcare Policy and Financing Agency, HICPOF, as you'll hear me refer to it, also through the 2019 legislative process, created something called the Hospital Transformation Project, which is really sort of a state version of what was happening at the federal level, but it's much more detailed. And I think the beauty of things like that is that it does force hospitals and communities to come together in a very predefined process and determine what are our needs. How do we look at the data? What does it say? What do we hear when we do patient focus groups about areas on which we need to focus if in fact we want to improve the health of the communities we serve? So I'm not going to read these one by one, but I do want to call out that increasing access to more affordable quality care clearly is one of the biggest crises and corresponding needs in our community. Improving availability and delivery of behavioral health. When we went through this process and we actually had surveys and we had focus groups, it was nice to hear, not nice because we want to have these problems, but nice to know that in fact we're focusing on the right areas. How do we prevent and manage chronic disease? And how do we do that in the mountains wherein we don't have enough population in some instances to ensure the quality of the services that get provided? What should stay local? What should go back to a metropolitan area? And then really this last piece is important. A third of our population here is Latinx. 50% of the kids in the Eagle County schools are Latinx. They are an integral part of this community. And they struggle the most, not just with health care because they can't afford it or they're afraid to get Medicaid because they're worried about ICE or whatever those situations might be. They got language barriers. Many of them are living in trailer parks where the quality of water is not where it should be, et cetera, et cetera. And we really have to make sure we're not leaving people behind as we go on this journey together. I encourage you, if you haven't done it, the URL, the website's there at the bottom where you can see this in greater detail. This is, again, another way to guide what it is we're doing for our community. So as a result, our top qualities always will be quality of care. How do we ensure that we're providing the best care possible in this mountain community? Lowering healthcare costs. Transparency. Someone already grabbed me as I was walking in and said, hey, are you going to talk about transparency today? So yes, I'm going to talk about transparency today, and I'm glad that this person did that because this is another opportunity we have, and one that I didn't have as much chance to focus on in year one as I was honing in on behavioral health and really laying the groundwork for more affordable care. But transparency, not just in billing, and by the way, our entire billing process is completely broken. And we're in the process now of totally revamping it and creating a new patient financial journey experience. It's going to take us time, but it's not just about billing transparency and making sense of healthcare bills. It's also about being more transparent in what we're doing as a management team and what's happening with our board and all the rest of those things. So you're going to hear a little bit more about that. And then, of course, behavioral health. So quality of care, and I'm going to speed up here a little bit to give us more time at the end. I don't think a lot of people even know what Vail Health is. As an example, Vail Health is comprised of a lot of these key subsidiaries that you see up here. So I think most people are familiar with the hospital. Many of you may have gone to the clinics. Some of you, unfortunately, may have had to go to the Shaw Cancer Center, and I say unfortunate not because of the care that's provided there, but because you're dealing with oncology and cancer issues at that point. Howard Head Sports Medicine. I know for a fact many of you have probably been there. The surgery center, you probably stopped there before you went to Howard Head Sports Medicine, or you may have actually had surgery in our hospital, but that's a piece of us. That is a 50.1 majority-owned, for-profit, JV entity, joint ventured entity with our providers. Providers is the new word for not just physicians, but folks like physician assistants and nurse practitioners and all the rest of that. There's a VVSC. We love acronyms in healthcare. Vail Valley Surgery Center, VVSC location. It started right next door to the Vail Health Hospital's ORs. That's why when you go in our hospital, you can actually see Vail Health ORs if you're having a more complex surgery, or VVSC ORs right next to it. There's also then, that was in 2002, those were built. 2012, 4 were added over in the Edwards location right next to the Shaw. Make sense? That is not the same as the nonprofit Vail Health Hospital, but it is a subsidiary of Vail Health. When we talk about transparency and we talk about letting the public understand better what Vail Health is, these will be coming out. They'll be going on websites. They'll be coming out, assuming we can get our colleagues from Vail Deli to let us put it in op-eds, which they've been extremely accommodating with us on. We're going to begin to tell these stories. And then what's the governance and management? What are the financials? All the rest of it. Colorado Mountain Medical, CMM. They joined us in middle of July. A lot of people ask me, Will, why are you doing this? Are you trying to get leverage to increase your reimbursement rates in the valley? And the answer was no. And that's evidenced by the fact we took the lower of the 2 rates. All the insurance companies will tell you that. But for us to ultimately get to a point where we do a better job of managing the population's health, which means once we get the costs down and people have the ability to access health care because finances aren't a barrier, we got to have enough primary care physicians, and that's not just an internal medicine physician or a family medicine physician, it's pediatrics, geriatrics, et cetera. And we got to have enough medical subspecialties, endocrinology, pulmonary, et cetera, to meet the needs of this valley. And inevitably, when we talk about bringing the cost of healthcare down, it's not just about bringing the rates down, which have happened and will happen more. It's about how do you help people not get sick? Get them to a primary care physician. Go see your gynecologist. Get your pap smears. Have your colonoscopies. Have your blood work run. You may discover that even though you're fit and you eat the right food, that you're genetically predisposed to high lipids or cholesterol. We may need to get you on the right diet and exercise, or maybe even Plavix, or something that's going to help with that cholesterol problem. Because if we don't do all those things, not only are you not well, you end up having blockage in your arteries, and you have a heart attack, probably on the mountain. Then we have to do a cardiac catheterization, maybe a stent, maybe surgery, and now all of a sudden, something that could have been managed in a much more affordable way is much more expensive. That's called utilization. How are you utilizing healthcare? How do we keep you out of the hospital? That's almost counterintuitive for a hospital administrator. Part of what we're trying to do, board, is keep people out of our hospital. You with me? And it's an important piece of what we're going to be doing as you hear me talk later in the day, but I want to make sure you understand even Eagle Valley Behavioral Health, 100% nonprofit subsidiary of Vail Health. We purposely branded it Eagle Valley Behavioral Health because we felt like it was a better reflection of what it is, which is a community-wide effort to address a major crisis in our community. So provider partners, these are folks that we don't own. It's not a subsidiary, but they're our partners. Castle Peak, if we didn't have Castle Peak here, I don't know what we would do. And thank goodness they are here because we need skilled nursing. We need a place for people at that stage in their lives. The Eagle Hope Center. For those of you who don't know what this is, I know Sheriff Van Beek knows it and loves it, and I know that all of our law enforcement does because I remember a year ago when I got here, they were throwing their hands in the air saying, we want to help, we want to protect, we want to serve. We weren't really trained to deal with acute behavioral health situations, yet we're getting called constantly. Eagle County Paramedics is getting called constantly. And they arrive and there's this situation where you're not adequately trained. They have a ton of training. They know how to diffuse a situation, but they had no place to take them. What are we going to do with these patients? And of course, that meant that they weren't doing the thing they should be doing, which is out there making sure that we're safe in other parts of the community. And so the Hope Center was created actually by our colleagues in Pitkin County to send out with EMS or with law enforcement trained behavioral health providers who do know how to do those things. And once we deem that it's safe and that that environment's not contributing to that behavioral health episode, then they actually stay in that person's home. Not over a period of time, but they stay there with them until that acute situation is resolved, until we can actually help them get the help that they need. And just a real quick comment about behavioral health, we're going to get to at the very end. The work that I've seen happen in the last year and the work that was happening long before I got here, by far, is the most impactful and meaningful thing I've ever seen in my career. The moment when we were in our boardroom voting on whether or not we were going to give the $60 million, there was almost a wrestling match for who was going to make the motion, followed by almost tears because it was one of those moments. And so I can't wait to talk to you more about that, but I want to make sure you understand this is not just Vail Health's responsibility. This is all of our responsibility. And we need to partner with one another. We don't have to own everything. That's not the point. But we do need to partner. Here's some of the services that we provide here. I'm not going to read it to you. The intention is to really say we provide comprehensive services here, and we do it so that people don't have to worry about whether or not they can make it through a pass, so that they can live their life here with some sort of assurance that, hey, if something happens to me, I'm going to be taken care of. So some of our patient safety efforts, because at the end of the day, quality and safety are highly correlated. And this was another opportunity I discovered when I got here. Some things were already underway, but as an example, daily safety huddles. How are we talking every day about what did we do right, what did we do wrong, what do we need to do differently? Really doing suicide screening questions. I'm sure if any of you have used our urgent care or been in some of our other provider offices, you'll see that this is now ingrained into what we do. What do we give back to the community in addition to what you've seen with Eagle Valley Behavioral Health? But what are we doing as a nonprofit? Charity care, putting the AEDs on the mountain so that in the unfortunate event that someone does have a heart attack, we've got the timely intervention that's needed. I'm not going to read through every one of these, but I wanted to make sure you understand that there is a component of community benefits that's happening every single day, every single year. We track this. Let's talk a bit, though, about lowering healthcare costs. Part of it is, how do we create a provider network, a network of care that is accessible, not just from an affordability perspective, but again, from a do we have the right doctors, primary care, medical subspecialists, so that people can get in and we can manage that care better? How do we make sure that we put urgent care sites out there so that in the event that you did perhaps sprain an ankle on the mountain or get a laceration falling on your bike, you can go to it in off hours, because these things typically are happening on the weekends or maybe in the evenings, and not have you go into a most expensive environment, which is our ED. And so sort of like the Zagat surveys, you recall when you're looking at restaurants and there's a $1 sign or $2 or $3. What we're trying to say here is we want to make sure that we are not only building out the provider network that enables you to get the care you need at the right price, but how do we educate folks? And how do we redirect when necessary? And then lastly, an emergency department, the most expensive area. And like inpatients, we should do everything we can to keep you out of there unless you absolutely need it. And we got a ton of work to do there. But it's much more than that. How do we start by trying to address the insurance premium problem? So healthcare costs are many things, right? But the thing that most people think about is, how does the end user, the patient, pay for it? How much do they pay for it? And there's a variety of different ways that people get insurance. You know, I joined the Vail Valley Partnership Board and really been partnering with Chris Romer this past year, who's been unbelievably helpful. But I never realized that there's 3,800 businesses in Eagle County. And 90% of those businesses have 20 or fewer employees. 80% have 10 or fewer employees. So that, and it kind of makes sense if you think about it, there's a lot of small businesses here in this valley, right? That means that if they offer insurance, and many of them can't afford to, which is why, again, we got to address this problem, but if they do, they have to buy it off something called the small group market. If they choose not to offer it or they can't afford it, they go to the individual market. So that's been a real big area of focus, is how do we get the insurance premiums down in the individual market and the small group market? Another big piece of our covered lives of our patients, our end users of healthcare in this valley, are people who work for large organizations, like Vail Health. We're a self-insured organization. Eagle County, Town of Vail, Gallegos, Colorado Mountain College, et cetera, et cetera. They don't buy insurance. They actually are self-insured. From an actuarial perspective, there's more of a cost benefit if they just pay the claims directly. They may use an insurance company that will administer it for them, but they pay those claims directly out of their pockets. And if you talk to a lot of the heads of HR, or really the CFOs of those organizations, they're holding their breath every month, waiting to see what the claims payments are, to see if they've matched what they accrued for. And if someone gets cancer or some really expensive disease, it could significantly outpace what they budgeted for it, which means then it's got to come from some other place. So we started really figuring out, what do we got to do to get the insurance premiums down? How do we make it cheaper for our large self-insured employers? Phase 2 is, how do we make, once you get it, when it becomes more affordable, how do you start to address high deductibles, co-pays, and co-insurance? Because if you were able to find enough money to get insurance, but then you're afraid to use it because you got a $6,500 copay, have you really solved the problem? Maybe not, right? A lot of people don't know this. One of the first things I did when I got here, and I knew it was a problem coming into it, I just didn't realize I was leaving the frying pan that was in Denver and jumping into the fire that was in the mountains. But I used to work for UPMC, University of Pittsburgh Medical Center. We were more like Kaiser in that we had 3 million covered lives on the insurance side. And so we were very much about how do you manage population health and what are the things you need to do. So I started with, let me get the data. It took us a while to get it. We got it. And one of the first things it said was only 48% of every insurance premium dollar that's collected in the Valley is going to Vail Health. Said differently, 52% of the insurance premium dollar that they pay out to hospitals and doctors and et cetera was going somewhere else. Now about half of that 50%, call it 25%, was going to Denver. And of that stuff that was going to Denver, some should have. We don't do pediatric subspecialties. We don't do strokes. We don't do transplants. But another portion of that 25% that was going to Denver was Kaiser, and was people voting with their own feet because they had a high deductible, and when it was time for an MRI, they didn't want to pay $2,000 plus at Vail Health, they wanted to pay $700 in Denver. That's smart, right? That's the market forces that have been missing from all this. What did those market forces do? Forced us to lower our MRI prices to $800, right? And I bring all of that up to you because if you don't have the data to understand what's happening, we could be creating the wrong solutions, right? We looked further at, where were we outliers? Where were we most expensive or more expensive than our peers? Where were people using healthcare in the wrong place? I'll use behavioral health as a great example. When we don't have enough behavioral health providers here, and people can't proactively manage that disease, and it is a real disease, their needs go unmet. Things fester, something happens in their life, an acute episode happens, Sheriff MB gets called, he doesn't know what to do, now he does, he's got Hope Center with him. They bring him back to our emergency department, they sit there for 72 hours while we try to find a place to send them because we don't have a facility here. They go to Denver or maybe Grand Junction, 30 days perhaps, without their family. Their family tries to get down there, but they've got to figure out how they make ends meet. We get them stabilized. They come back here. There's no providers. Repeat process. So not only is that highly ineffective, it's very expensive. And so how do we begin to take the data that shows how people are utilizing healthcare and put solutions in place? It's one of the reasons Eagle Valley Behavioral Health is a key component to lowering costs. Those two things are highly correlated. Does that make sense? So I'm not going to read through the rest of these, but I do think it's really important you understand there is no silver bullet, there's no one solution. It's going to take everything. Things we create, things that happens in the Colorado legislation, things that will happen from the federal government. Inevitably, it's going to take a variety of things to solve this problem. This is what I was describing to you guys earlier. There will not be a test at the end, but if you really want to understand what it is that I'm saying, it's important for you to understand that when we talk about a people that's 50,000 or so that live in the Eagle River Valley, you either have commercial insurance, and that's about 60%. You have government insurance, which may be Medicare, Medicaid, or some form of TRICARE or things on the military side. That's about maybe, 20%. Or you're uninsured. And actually, as you know, sadly, we're more in the 13-14% range here. And why? It's too expensive. When we fix the problem of making it more affordable, that number will go down and it'll likely shift over into the commercial side of things. Legislative perspective, it's hard to understand what all of these things mean. Reinsurance, insurance for the insurance companies. So insurance companies collect premiums and then they use those premiums to pay hospitals or pay doctors. Like a self-insured organization, if they have a huge bill coming for somebody who had a transplant or major oncology services. That could be the thing that breaks the bank for them. So reinsurance is actually an insurance company files to say, hey, if I have one of those big claims, someone's going to pay me back a portion of it. Does that make sense? And those savings actually got applied to this segment of the market, right there. At the state level, that probably represents between 6 and 8%. My numbers are probably wrong, but I'm ishing it. Ish. Here in the mountains, it's bigger. Why? Because I just told you 90% of our businesses, 20 employees and less, many of them can't afford it, so they push people to the individual market. Purchasing collaborative, insurance purchasing collaborative. Does everybody understand what that is? How do you have all the businesses come together instead of negotiating through an insurance company or on their own? How do you pool your collective negotiating power and do it directly with a provider, a hospital, who oftentimes there's cross-pollination on boards, or, I'm sitting across the table from an Eagle County commissioner, one of whom's on my board, and forcing a tougher conversation as opposed to just having hospitals and insurance companies pass that on to the end user. It makes sense. It does. The Peak Health Alliance, have you all heard of that? It's in Summit County. That was the first place they started this. We actually shamelessly stole a lot of their great ideas, but molded it a little bit to fit what we felt would be better for our community. Chris Romer in the Vail Valley Partnership is the person with whom we've been working on this. We have a team of people from the community, insurance brokers, heads of HR from large self-insured places, other business people, to help us say, what do we need to do to make sure that we're offering a lower cost option, I'm trying to get back to here, for all of this, and not just here, or here, or here. Make sense? I know it's boring. I'll go a little bit faster. I get really excited about this stuff, and Michael starts glaring at me saying, "Will, speed it up." Don't hide behind the complexities of what's happening in the Colorado legislation and the federal government. You got to figure it out. You got to pay attention to it. I'm not trying to lecture you, but the stuff that's happening with the public option at the state level and what's going to play out in the presidential election, the Medicare for all, something else, is hugely important. It's probably the most important thing that's going to play out in both sets of elections. Please understand it. And if you want to know more, you can call me or email me, and I'll walk you through it. I'll come to your organization. I'll come to your meetings, whatever it is you need me to do, but pay attention to it. Everybody knows RAND, I think, right? They do these wonderful studies. But the fact that it took a RAND study to try and explain hospital prices tells you there was a problem, right? And you'll hear a lot of people talking about, reference pricing. What do you get in terms of commercial insurance rates relative to Medicare? What percent of Medicare are your commercial insurance rates, right? So there was a study that was done, and it looked at a variety of states. They especially looked at Colorado, and they in particular looked at the ones that were in the mountains. And if you look at, this is their data. This is not my data. This is their data. This is where Eagle County sat. We're the only hospital in Eagle County. Okay? Now, we get something called a sole community provider status kicker, which makes our Medicare rates a bit higher. So our percent of Medicare is a bit distorted. If you normalize for it, we're still in the mid-300s. Now, if I would have said, I'm going to take a poll by a show of hands as to whether or not someone thinks that Vail Health's commercial insurance rates are less than Valley View, how many people would have said, yeah, I agree with you? She's seen the answers. Close to zero. Because we've done a horrible job of proactively telling our story. And oh, by the way, let's not lose sight of the fact that 350% of Medicare is not affordable. But it's important that you see these things and understand it, because all of these data points are things that are going to help us ultimately figure out, how do we fix the problem? I can't fix the problem in the valley if only half the people are coming to us. You with me? So moving on from it, the Mountain Healthcare Coalition, again, I talked to you about it briefly. It's the Valley's version, our Valley's version of the Peak Health Alliance, slightly modified to fit what we feel are our needs. It's a subsidiary of the Vail Valley Partnership. We don't want Vail Health. We can't be a fox guarding a hen house. We need an independent outside party who's advocating for the businesses that it serves to work with us on solutions. So that's how that's set up. Again, this is all part of the transparency piece, so you all know what's going on. You know, Kaiser left the market. That was a big deal. Really big deal. Instantaneously, when I heard about it, I was working with Anthem on the data I'd already had pulled from the Center for Improving Value in Healthcare, pulled in the actuarial firm that worked on the Peak Health Alliance initiative and said, hey, help us make sense of this. We need a solution. If Kaiser leaves and they're not on the individual or the small group exchange in January of 20, and we don't replace it with something cheaper, then we've exacerbated the problem. So we did it. Unfortunately, we missed the filing deadlines. In order to offer lower rates and in time for your traditional sort of fall open enrollment period that goes into effect in January, you have to have your rates turned into the insurance companies in March, because they got to get them into the insurance commissioner by June, because he has to go back and make sure that everything's appropriate and kosher. And then they give it back, and that's when the health insurance plans wrap plans around it. They structure plans based on the rates, on the utilization, and all these things. So the lead time is pretty high, and I was 90 days into the job, and I already missed the filing deadline. Fortunately, the reinsurance solution that came from our legislature solved, at least for 2 years, the individual market problem. And it let us turn our attention to small group, and that's one area where you don't have to buy it just once a year. You can get it quarterly. So we gave Anthem deep discounts. We looked at their data on where their pain points were with the utilization side of the equation, and actually came up with something that's cheaper than the Peak Health Alliance. And it's going into effect on April 1st. We're working with all the insurance brokers to educate them on how to educate people who had to pay the higher price in January to get them to switch. These are real meaningful things that we're doing to try and lower the cost of health care. It won't stop there. It won't stop until it gets to a place that's more affordable, and it's not going to stop with premiums. We have to look at deductibles. We have our hands tied in the individual markets, but we don't in the other markets. So stay tuned on it. You're going to hear more and more about this. Transparency. You think about it, I always think of Southwest Airlines, transparency, and I always think of organizations that have been really proactive with putting it all out there. Huge opportunity for us. That's not been what we've done in the past. That's not a criticism on my predecessor. It's not been something that I've seen happen at any of the places I worked. All prestigious organizations, UC Health, UPMC, Hopkins, we all hid behind it. It was easier to, right? But we're at a different place now. And it's time to start talking not just about what our prices are, but other things as well. We're starting with prices because it's highly correlated with lowering the cost of healthcare and helping people who do have high deductibles figure out how they pay as little as possible. So shoppable services, we looked at all the services that were most frequently being paid for out of pocket, and it makes sense in this mountains. Most people, I think we're number 1 in obesity in Eagle County and all of the state of Colorado. Least obese. Somebody just goes, what? Everything you've set up into this moment, you just lost total credibility on. Like, I'm from Mississippi. We were number 50 in everything, except for obesity, so I said it wrong. We were number 1 in terms of not being obese. It's a very active, and it's not just obesity, it's about, there's a lot of people who are active here, who are very healthy, and who do it in large part because they want to enable themselves to go out and get into this powder tomorrow. Interestingly, a lot of meetings started falling off my calendar for tomorrow. Rick. I'm kidding. Rick and I have a meeting tomorrow morning. He's probably going to ask me after this if we can cancel it. In all seriousness, though, it comes back to this is a relatively healthy population. So when they do utilize healthcare, other than those things that are genetic, like you can't avoid what your genes say you're going to have in terms of cardiovascular disease, that's inevitable. You can't avoid, oncology and that sort of thing. But, what usually is happening, someone crashed on their skis or wrecked their bike and they got to have their ACL done and this, that, and the other. So that oftentimes means the very first place that they're spending down their big deductible is for some form of imaging, and typically MRI. So Vail Health was $2,000-ish, depending on which part was being MRI'd, if that's even a verb, and depending on if you had contrast or not. And you recall that in Glenwood Springs, they were more like $1,200-ish. In Denver, you could get it for about $800. So that's why we took our MRI rates and dropped them down. Now, I don't control all the MRIs. Some of our provider partners have their own MRIs, and I can't tell them what prices to set. But if you come to one of our MRIs, that's what the price is. And we're going to dig deeper and understand which other shoppable services do we need to drop our prices on, because some people are paying out of pocket, a large number of people are. We're going to ultimately get the patient financial journey going, where we're going to start with totally blowing up billing. It is completely broken. I've made changes at the highest level of the organization in finance. I did the same in IT. Both very good people, but I did it because we can't continue to do things in the present or the future the way we've done them in the past. And I didn't in my first year see us actually make meaningful movement towards doing that. We have to start almost entirely over, unfortunately. But when we get that done and the platform's right, then we're going to start talking about how we assign people financial counselors, a liaison of sorts, to help you make sense of it. How do we, if I could get to my iPhone, I'd whip it out, but how do we have this be on your smartphone through an app? It shouldn't be that hard. You need an MRI? Here's what we charge. We can interface real time with your insurance company and find out, as of February 6th, what is Will's current balance on his deductible? What does his plan say in terms of copay? It should feed it right back over and tell you, this is what Vail Health charges, this is what your insurance company is going to pay, and this is what you're going to pay out of pocket if you don't use any more healthcare between now and when you have this procedure done, because you can further bring your deductible down. How do I know this? I helped build it at UC Health. But you can't build sophisticated technology solutions on top of broken operational business processes. And so I'm trying to untangle, rebuild, and then layer it on top. So I apologize for those of you, especially here recently, as we finally fixed some of that stuff and we're doing backlog claims billing. My phone's been ringing off the hook with, what in the heck is this bill from a year ago? I put a cease and desist on it. I'm going to try and figure out how we make it right. But what I'm telling you is it's almost like Maslow's hierarchy of needs. I'm on that bottom little piece of that triangle right now, and we're working on it. It is going to be a priority for this year. It's why transparency is one of them. You heard me say earlier before I jump into behavioral health, it won't just be in our patient billing and navigators and that sort of thing. You're going to see us continue to put things out on our website, in the newspaper, through meetings like this. Our board, who's been unbelievably supportive of this, in fact, has been giving me great direction, created a new community outreach committee of the board. Andy Daly is chairing it. And we're identifying all of our key community stakeholders with whom we need to go meet and talk about, hey, here's what's happening in our organization. Where are we missing the mark? What do we need to do differently? Understand our financials, understand our governance. There's nothing to hide here. But it's going to take us some time, as you can imagine, to get that done. Behavioral health. Man, I wish I had Chris Lindley here today. Not because I can't speak to this, but because he's infectious. And I shouldn't say that when the coronavirus is going on. And in fact, he's also some epidemiology, former CDPHE, former with Eagle County He's been very involved in the coronavirus as well. It's probably what he's doing right now. But man, what a galvanizer he's been. We shamelessly poached him from Eagle County. His boss was one of my board members, Jeff Schroll. Suffice it to say that initiative, which started before I got here, which included law enforcement and EMS, I see Chris over there, and the Hope Center, and providers from not just here, but Mine Springs, CMM, schools, everybody was involved and at the table, tops of the organization. They created this thing that we have today called Eagle Valley Behavioral Health. We put it in Vail Health in part because as the sole community hospital in this valley, we needed to be on the forefront of this. It needed the governance and management and infrastructure that would withstand governmental turnover in positions. That's not meant disrespectfully, it's just the nature of the beast. It needed resources, meaningful resources, not 6 million, it needed 60 million. Not 60 million, it needed 100 million, 160 million, which is why we agreed to raise another 100, and it probably needs more than the 160 million, it probably needs 260 million. And we're going to not just fix the current crisis, which a lot of it is just the symptoms of not having enough care here. We're going to get to the underlying problems. And you know what we're going to discover when we peel that onion back. People move here and don't have a support system. They get here and it costs too much for housing and health care. There's this tough mentality of I'm in Colorado, I climbed 14ers and I broke my leg and still skied down the mountain, and all these things I'm just discovering. But there's a mentality that's not conducive with asking for help and for asking for help. And I'll tell you though, one of the big things that got identified was we need more providers, again, more psychiatrists, psychologists, licensed social workers, care managers, compared to the state average. And the state, unfortunately, was like 42nd in the nation, which is not good. We needed 50 more providers, 50. We stood this thing up. It went into effect July 15th. As of today, we brought 31. 31. We've done an anti-stigma campaign. We've set up a database that lets people go to know where they're getting services. Chris has helped pull together the insurance commissioners, say, what do we got to do to get reimbursement higher in the outpatient setting, which is a more effective place to treat it than in an inpatient setting. We're in the process now of figuring out, are we doing a crisis stabilization unit, which is not an inpatient facility, but a place where people could stay overnight, or are we going to go full-fledged inpatient? We're talking about big things, not small things, because we got to get it right. And when people say, well, what is Vail Health doing with all that money they made? And what are they doing to fulfill their nonprofit mission? And what are they doing to help this community? This is an example of it. Addressing the issue of the cost of healthcare is an example of it. Trying to engage with everyone to understand what do we need to do differently is an example of it. We're not there yet. It'll take us 10 years to get this right. But man, I can see the light at the end of the proverbial tunnel. And we got a plan, and we got community partners. So please, if you haven't been engaged in this yet, get engaged, because probably the most important thing in all this, it takes a community. It's almost like security. See something, say something. I don't know the scientific source of this, but there's a statistic out there that says if someone sees that somebody else is struggling, they're not acting themselves, and they say one little simple thing, Will, are you okay? That can change the odds of them committing suicide by 80%. 80%. Gotta look out for your neighbors, you gotta look out for your coworkers, everything. So I really encourage you to please get involved with this. It's a hugely important initiative that we're working on. I'm not gonna, again, read through these. I think most of them you know by now. But what really matters is we got partners. And we're working together to raise money as opposed to competing for a very limited amount of funds. We're sharing information. People ask me about Colorado Mountain Medical and why that was a good move for both parties. Number one, if I don't have a primary care network or medical subspecialty, I'd have to build it on my own. It would compete with CMM. It would be a waste because there's not enough patients to stand up two of them. But also, CMM couldn't afford to hire behavioral health therapists, psychiatrists, psychologists, and integrate them in primary care, which is the most effective way, by the way, to catch this and beat it. But once they joined us, they could. They've got 5 behavioral health providers, psychiatrists, psychologists. It's right there in the middle of their primary care offices. There's a warm handoff room that if someone's seeing someone for a physical or even for a subspecialty appointment, they discover there's an issue, they walk them down the hall and they put them right with a behavioral health provider. We're putting them in schools. We're putting them in other places where they're desperately needed. So none of that can happen again without the entire community coming together. And we're grateful for those of you, I see many of you in the audience, who were very much involved with that. Lastly, a lot of jokes out there, but the state bird for Colorado is the crane. And not the kind that flies like, you know what kind of crane I'm referring to. I want to make sure you all understand, and you probably know this better than I do, the facility that we have there, not all of it, the new West Wing was built not too long ago. It is outdated and antiquated. Future slides, I want to put the ones I took pictures of when I first got here, to a point in which we couldn't even get things repaired anymore. We've been in violation of parking, don't tell any of the law enforcement people that are here, for a long time because what we had built out was no longer big enough to accommodate what we'd grown to. There's plans to ultimately turn South Meadow Drive into pedestrian only. That's how you get to our hospital. And oh, by the way, if you haven't really updated your facility since 1973, it's probably a good time to start doing it. And this facility will last us for 30 or 40 years. And guess what? The next administrator like me in 20, 30, whatever, will be standing up here saying the same thing to you all. And they should. We have a responsibility to do it. America needs to invest in its infrastructure. And so that's why this is happening. And I'm excited to tell you that actually, as of today, and now it's been really cold and all this snow keeps me up at night. On one hand, I'm excited because it means it brings people to our valley. On the other, I'm like, can you really pour concrete if it's below 18 degrees? What does that mean for our schedule? Parking garage, 475-ish spaces, new emergency department, new imaging with a new MRI that's like the 3T. You won't have to worry about going to Denver for 3T anymore. It's the new technology. You can do same thing with a 1.5 Tesla that you can do with a 3 Tesla. This is an extremely important part for not just Vail Health, but for our community. And I want to make sure you understand we're trending towards end of 2020, first phase in opening. It'll go into early of 2021. Stay tuned. It could change. It kind of depends on what happens in February and March. But even if we're off the market, it would be in a matter of weeks, not in a matter of months. So we're excited about this, and you all should be excited about it. And as it gets closer to opening, we're going to do all sorts of open houses, invite people from Vail, from Mid-Valley, from Down Valley to come in and look at it and understand what does it really mean.